There is some kind of file got corrected. This is basically an angiogram of a 60-year-old male who had inferior ST elevation MI 3 days prior, and he's a non-diabetic, non-hypertensive, and had uneventful recovery. He had a successful, thrombolysis. This is the injection showing the left side, and the left system is quite normal. The right coronary shot was taken, and then the next slide, please. Next slide. Yeah. The right coronary shot was taken, and that shows a mid short segment significant residual disease. It was profiled in more than one view. And after this, we took consent from the patient and attendants regarding the ad hoc PTC and stent to the right coronary artery. We promptly took a GR guiding catheter and a BMW guide wire, and then I want to dilate it with a 2 into 13 mm balloon at around 8 atmospheres. We got a good result, and then probably we wanted to stent with 4 into 19 mm bare metal stent, which was deployed at around 12 atmospheres. After this 4 into 19 mm was deployed at 12 atmospheres, I was little skeptical regarding the mid part of the stent, so I took 4 into 11 mm and went up to 18 atmospheres. I saw that little amount. Can you keep playing the previous one, previous one, previous one, previous one? While I saw some little amount of whatever you call it as a kind of a bulge kind of thing, probably overinflated, or kind of a prolapse of the balloon. Next slide. I just made sure that my balloon was within the stent. Next slide. Because I thought I came little down. I was out of the stent. That's what I feared, but I made sure that the balloon was quite well within the stent. And then after removing the balloon, I took a shot.
Perforation.
Next slide. Yeah, this is what I have seen, which I retrospectively diagnosed as a class 3 perforation, cavity filling perforation. And then I had few options in the cath lab. The one option is, can you pause here? The one option I had is to inflate the balloon at the site of perforation at low atmospheres, and then reverse the heparin with protamine. The second option, of course, what I had is to put a cover stent at the same place. The problem is I did not have a cover stent in my rack. So I at the same time, I don't want to give protamine and probably close down the vessel and then lose the vessel. So I basically called for help. So the help said the stent would come probably 10-15 minutes. Meanwhile, I was keenly observing the pressures. Pressures were quite well normal. The ECG was quite normal. The patient was hemodynamic stable. He was not symptomatic. Can you go to the next slide? And then after say 12 to 15 minutes, after around minutes, the stent was there in the lab. The patient continued to do well. Next slide. And we chose around 3.5 into 23 over and under pericardium covered stent to cover the perforation. Immediately after noticing perforation, we called echocardiogram into the lab, and we kept seeing for the pericardial effusion. I also called my colleague to be in the lab, and then we kept watching closely. I also made that the pericardial synthesis set was ready. We also made ready for a temporary pacing if needed. These were all done as soon as we noticed the perforation. Vis-a-vis the PTFE covered stents, the pericardium covered stents are little recent and probably more flexible, and probably they are better. Can you go to next slide? Next slide. Okay. This one. Which one? This one. So at this time, when I took injection, the pericardium cover stent was at my hand, and soon when we were taking out and then threading onto the wire, patient had a cardiac arrest and then bradycardia followed by cardiac arrest, where he needed a CPR and atropine, and you can see here the heart rate has jumped. And then I felt, if you see that, the pericardium cover stent was not getting into the through the first stent, basically because little bulky. So after some kind of nudging and prayers, it just went, and then we positioned it appropriately against the perforation and started inflating. When it started inflating, it was not inflating properly initially, and then it inflated, and then we removed it and then took one injection. So the injection showed a little amount, the injection showed no reflow or no flow. So after some amount of nitroglycerin, soon the flow got cleared. There is some kind of a spasm down under, but I know that it's only a spasm. There was some little amount of leak was persisting, so I took 4×11 balloon and inflated at that juncture where the little amount of residual leak is still there. And after inflating, I wanted to take out the balloon. The balloon was getting stuck at the next slide. So balloon was getting stuck and not coming out. Then I realized that the balloon got probably ruptured, and I had to take the whole unit out. And then again I went again and gave injection, and this time I was quite happy that I have sealed it completely thoroughly, and there are no more fresh leakage. And things went on well, and then probably I salvaged the right coronary artery, and all through these the patient was quite hemodynamic stable. He received 70 units of infraction heparin, and then his ACT was around 200. And when we are just then closing down the session, my technician said, the patient has hypotension. He says BP fell to 70 millimeters mercury, and he was having a classical pulse paradox in the arterial tracing. And then we realized that he has a pericardial effusion, so we had to do a pericardiocentesis. Well, after the about say 5 minutes hours after the deployment of the covered stent, which was done of course promptly, and then patient was shifted to the ICU. After getting into ICU, after half an hour, patient complained of significant shortness of breath, and then he was noticed to have heart failure. His echo was done, and then can you just stop playing? The echo was done, and the ejection fraction was quite good as it was previously, and we thought it may be diastolic heart failure. He was a little intubated, and he was kept on ventilator for next 24 hours, and where he was promptly extubated. And then he continued to do well. He was discharged on day 3, and he continues for follow-up. His 8th month of follow-up. He's on dual antiplatelets and doing well. This patient is being presented only to see that, to show that beginners at least that probably I oversized the stent. Probably it was 3.5 or 3.25. I made it to 4 and went quite up to 18 atmospheres. That again probably because the previous day I did a couple of stentings which I was not very happy with the size, and probably I want to correct the mistake, so-called mistake in the previous patients in the next patient, which probably should not be done. And probably also a kind of a lesson that we should have always a cover stent in the cath lab, and then we need to probably keep be prepared for pericardiocentesis and keep expecting a pericardial effusion, and then have a colleague probably at hand, and these are all the few of the things that probably I would convey. Thank you very much.
What was the atmosphere at which you deployed the covered stent? What was the atmosphere at which you
The covered stent was deployed at 7 atmospheres. The nominal was given about 6 atmospheres.
So why do you think there was a persistent leak after the covered stent was pulled?
Probably the covered stent was not opposed to the wall, and probably there was a little amount of leak. Probably there was still a gap there.
But the patient had pericardial effusion before you put in covered stent?
Yes, after putting the covered stent, patient had a pericardial effusion.
Before putting that,
he had a very, actually I was observing the echocardiogram closely. He had a very thin film of pericardial effusion, and the effusion was quite gross and hemodynamically unstable only after completion of procedure. The literature says that
normally in coronary perforation, one has to go step by step. You see that whenever you have perforation, you have to put the balloon first, so that you have the prolonged inflation of the balloon, reverse the heparin, and most of the patient, in fact, like the type of perforation you had, which was not very large, probably the large perforation probably would have collapsed immediately at the moment you would have removed the balloon. Most of these patients actually do settle without putting covered stent. Covered, you know that the covered stent, in fact, many times create a lot of problem. Lot of problem in that sense that never endothelize, the endothelialization is poor, the stent thrombosis rate is in range of 10 to 15%, then the restenosis is about 50-60%. So practically most of these patients are going to come back to you. And if the patient is hemodynamically stable, there is no point of rushing for putting in covered stent. Because 70 to 80% of these patients do settle without doing anything. In fact, if you would have waited for maybe half an hour, then the things would have settled on its own.
What we probably thought was is a class 3 perforation, and then doing anything at that juncture, at that site where there is a perforation already with a low inflation probably would worsen the problem, and probably I can do better with a cover stent, especially when I had a pericardium cover stent.
No, that's fine, but you omitted the step 1 and step 2. You never put the long inflation, you never reverse the heparin, which is the important part.
That's basically because I was quite observant, and I was ready with such kind of step.
Yeah, that absolutely illustrates that the commonest cause of perforation is the oversizing of the stent. And you have a point, Sushil?
Yes. Well, one question is, or one technique that we use sometimes with perforations. The main issue is the instability, and if you're getting this was reasonably contained, but if you have a free perforation into the pericardial space, using a dual catheter technique is sometimes an option to avoid the instability. You immediately tamponade the perforation with the balloon, so there's no more bleeding into the space, and then while you're reversing the heparin, you get access in the other groin, and go up with another guide catheter. When you have the balloon inflated, you pull the original guide catheter out, you engage with the second guide, and through that second guide you can put a wire and get your covered stent if you need to deliver it. The reason that we do this is that way the amount of time that you have the balloon deflated is minimized. So sometimes if it's a big perf and you need to cover it, when the balloon's deflated, patient gets hypotensive as you start getting more and more blood going into the pericardial space. This way you have the balloon is deflated, immediately the stent is advanced. If you can't advance the stent for whatever reason, you can go back up with the balloon and tamponade. So that's a technique that sometimes used with very large perforations. And it may be useful in addition to a pericardial drain and everything else to stabilize the patient quickly. I think Dr. Somaraju has a question as well.
See, originally you deployed the stent which was a 4 millimeter diameter, and your covered stent was what, 3 or 3.5? So how did you think that which was already dilated the vessel to 4 and 3.5 would work?
Can't get your question.
The covered stent was 3.5, sir. The previous stent that was put in the initially, the environment stent was around 4. Yeah.
4 at very high atmospheres, and 3.5, how does it work? Conceptually, how does it
cover the
work?
4? That's a pretty valid question. Probably those were the limit. That's the reason why.
Is it because that you did not get a 4 millimeter covered stent? Was it not available?
That 4 was not available.
Not available. Normally we get normal sizes at 3 and 3.5.
Actually, I feel luckily 4 was not available. If 4 was available, you would have gone into more serious trouble actually.
Thank you.